Good afternoon. Am I ready to start? I think we have people filing into the room. I'm getting a thumbs up. Right, I'll take that as a yes. Welcome everybody on this rather hot afternoon. We have a really good session for you today, we hope. A really warm welcome. I am Caroline Rogers. I'm one of the Associate Directors at HQIP. And we are going to announce and celebrate, learn from the winners of the innovation category of the awards. We've got 45 minutes today to end at 1:30. Please note that this event is being recorded and we hope to make the slides available to you in due course. And if I could have the next slide, please. The event is part of Clinical Audit Awareness Week, as I'm sure you all know. It's a week-long campaign. We're celebrating and promoting the critical role of clinical audit and data in improving healthcare. And we're with the aim of improving experience and outcomes for all of our patients. And the week includes the Excellence in Clinical Audit Awards, recognising individuals and teams who are transforming healthcare through their good clinical audit work and their evidence-informed improvement projects. And a real highlight of today's event is we have a speaker and we will find out about the winners of the award and we'll hear from the speaker directly about their work. So thank you so much for giving up your time today and attending our event, and thank you and welcome to our speakers today. Could I have the next slide, please? We have a few housekeeping notes. Not sure if anyone's able to see the next slide, but I'll carry on because I've got some housekeeping notes. So just to let you know that all the microphones are auto muted just to avoid any background noise, and we'd like people to have their cameras on if they can. The chat function is turned off. We're going to use the Q&A function to pose questions to our speakers, and we'll have a dedicated Q&A section at the end of the session. So please do submit your questions in the Q&A function. There's a button at the top of your screens. So we've been Microsoft advised that for this kind of webinar, it's best to use a laptop or a PC, not a phone, and the browser version of Teams to get the full experience. So we hope that's working for everyone. If you do have any problems, you could try switching to the browser version. And if you're unable to access the Q&A and have a question, please do, after the event, you can always contact us using the Contact Us form on HQIP's website with any questions that you have. And if we have any technical issues, if you just wait a few seconds and then rejoin with the original link, hopefully it will work for you. We encourage everyone to share this event and any activities that you're running during the week on social media, and the hashtag is hashtag CAAW26. So we can shine a light on the importance of our work and of healthcare improvement this week. Now, we get to the fun part. Hopefully I've covered all the housekeeping and we are ready. We've got one runner-up and one award winner. And then we have Vicky Patel joining us. And Vicky's done a great job of providing some commentary this week on our awards. So we welcome Vicky to make some comments. So if I could have the next slide, please. Today I'm going to be announcing the Innovation Award. Next slide, please. The runner-up is, next slide, please. It's the team at Whipps Cross University Hospital, the End of Life Care Champions at Barts Health NHS Trust, with their project on transforming end of life care, a champion-led quality improvement approach. And there's the team. So well done to those. And I've had some lovely feedback from the awarding panel, so I thought I would share that. So this is about the use of the NACEL audit, National Audit of Care at the End of Life data. And the panel felt that this work had an excellent clarity of vision from the outset and used this to create compelling dashboards that include bereaved families' experiences. The panel were particularly impressed with how this work was integrated into existing practices and made use of champions to promote learning. So well done. We thank you for entering and congratulations. Next slide, please. The winner is, next slide, please. We have the Data Science and Infection Prevention and Control team, Newcastle upon Tyne Hospitals NHS Foundation Trust. And the project submitted, there's the team there. So well done, our winners. The project was Reproducible Analytical Pipeline for Rapid, Sustained and Statistically Significant Improvement in MRSA Admission Screening Compliance. And we are going to hear much more about this project, but I thought I would just share some of the panel feedback. And the panel felt that this work demonstrated a highly innovative use of data that were already available from different sources in the trust, but combined them in a way that had a measurable impact for patients whilst being resource efficient for staff, given the automation built into the pipeline. The panel was delighted to showcase this work through the Clinical Audit Awareness Week and hopes that it provides the opportunity for wider sharing of the approach and the code with other hospitals. And our next slide, please. I am going to introduce Daniel Weiand on behalf of the team to talk about the team's work and so that we can all learn and all celebrate together. Daniel, over to you.
Thank you very much for that great introduction, Caroline. You've already introduced what I'm talking about, so please go to the next slide. This is my team who I work with, and I'm most grateful to every single one of them and also others who aren't listed here for all the really important work that they were involved in over the course of several years in order to make this project a reality. My colleagues here include colleagues working in information services, IT, the data warehouse, the microbiology laboratory, and also infection control, as well as the clinical informatics leadership of the trust. So thank you very much. Next slide. So I wanted to start by just outlining what a reproducible analytical pipeline is. If you press forward, please, one time. What we're talking about here is a process by which code is used to extract information from one or more databases. It pulls that data in a scripted form and then transforms it, processes it, analyzes it, and ultimately produces a report, all using code which makes the process much faster, more robust, and more transparent than conventional manual processes. And this is a really important key takeaway from this meeting, because this approach is not very often used currently, but it's not rocket science, and it can be applied in many other settings. As long as you have access to the data, ultimately the raw data in the database, then you can build a reproducible analytical pipeline on top of it. Next slide, please. So what RAP, as I'll call it from now on, helps with is changing slow reporting cycles. So for example, as a medical student, you're used to doing audits every 2 or 3 years into rapidly repeatable cycles. So we can run this audit every week now. We can also enhance trust in data because we know how the data has been pulled, extracted, processed, analyzed, and reported through version controlled code. So it's a pipeline that's fully auditable over time, and I can outline exactly how the data has been processed to come to our conclusions. This also helps with reproducibility and transparency of the actual output. And I often get emails from staff members who now have access to this sort of output, and they want to know exactly what it means for them, and I can have sensible conversations with them outlining exactly how the analysis was produced, because a RAP supports transparency. And as you've already alluded to, Caroline, what this helps with is making processes auditable that otherwise would require tremendous human resource. So I'm going to talk about MRSA admission screening compliance, and there isn't much baseline data on this because to ultimately check to see what compliance is like manually is such a mammoth task that people don't do it. And ultimately, the process itself of RAP helps implement evidence-based decision-making into clinical reality. Next slide, please. So the problem I'm describing here, which is infection control related, is about bloodstream infections, MRSA bloodstream infections particularly, which are of significant national interest because they feed into the national frameworks that organizations now get ranked by. So in Q2 of 2025-26, our trust, Newcastle Hospitals Trust, was 22nd, or in segment 2 of the dashboard. But importantly, we were 125th out of 134 for the metric number of MRSA bacteremia cases. Click forward, please. So the report is publicly available. This is not secret information. It's all available for every single trust across the entire country. Next slide, please. Now, coming to the evidence base of what can be done to improve our MRSA bacteremia rates, there's 7 or more things that can be done that are widely accepted as things that do help. And the RAP helps with many of these all at once. So it helps make fully transparent, auditable data available in a timely fashion to key stakeholders, which ticks the leadership and engagement and governance box. It also makes best use of technology and supports prudent antimicrobial stewardship, because if you know that someone is MRSA positive, then you can facilitate a review of their antimicrobial prescriptions and improve the patient care. It also helps with surveillance. So previously, prior to this RAP being introduced, we didn't know what our compliance with key measures was, but thanks to the RAP, we now do. And it also helps with understanding of universal screening and decolonization protocols, because we extract data from multiple different sources and triangulate it in order to come to a conclusion about whether we actually are screening our patients appropriately or not. And if we're not, then sharing that information with key stakeholders in a way that allows them to improve patient care. There are other things that can be done as well, like staff education and competency, and to some degree, this project has helped with that because it's led to greater engagement about the need to do MRSA admission screening appropriately. It doesn't help with some things like hand hygiene, compliance, and rigorous environmental cleaning. So it's not a panacea, but it is a really important tool that has helped us address several things that can help improve patient care. Next slide, please. So to give you a bit of context for us in our trust, screening for MRSA is mandated for practically most inpatients. There are some exceptions, but for most patients, it's practically a requirement according to the Trust MRSA policy. And the Trust policy says that screening should be undertaken between 18 weeks preceding admission up to the admission date. And as I mentioned, it would be a brutal task to actually do this kind of audit just once manually. So we didn't know what our MRSA admission screening compliance levels were prior to this RAP being introduced. Next slide, please. Click forward 3 times, please. Yeah. Just to say that this model of screening regularly and or rather doing surveillance regularly and then sharing the output with key stakeholders is evidence-based in the medical educational and QI literature, because basically what we're trying to do is monitor and report on performance with MRSA admission screening for particular areas in the hospital, which then drives understanding about how we're doing, which then drives improved practice. And that's a process called normalization process theory. Next slide, please. So there's a book on this subject, which can be read under the heading of implementation science. And I think it is really important because these things are theoretical, but in practice, what we're finding is that implementing this in practice is very fruitful for our performance. Next slide, please. So the aim of this project was to implement a RAP that triangulates data from different silos to prospectively evaluate, report, monitor, and improve compliance with MRSA admission screening practices. Next slide, please. Our trust is very large. It has approximately 16,000 staff members, serves 2 million patient contacts annually, and the lab, just for completeness, is fully UCAS accredited. Next slide, please. So here, a bit more information about the RAP. What we've done is used modular reusable, Git version controlled code to extract data on a weekly basis from our secure data warehouse, which is a Nautilus data warehouse, using programming languages, including SQL and R programming. R programming is then used to wrangle the data, which involves cleaning, quality checks, and analysis, to then produce outputs in the form of HTML format reports produced using Quarto, and that's ultimately uploaded to a secure central intranet hub for staff to be able to access this data. And this whole process from start to finish is run in one script. So you don't extract the data separately, then wrangle the data separately, then use the final output or produce it in Quarto separately and then upload it. It's all done from start to finish in one script. So every Tuesday, I'll run the script, and then the output is automatically, in a quality checked manner, uploaded to the data science intranet site. And that's the power of the reproducible analytical pipeline. It makes what would ultimately be a really big undertaking possible within 15-20 minutes. Next slide, please. So this is how our intranet site looks. It tells you about the site. It reminds colleagues about the principles of information governance, Caldecott principles, and it includes a whole bunch of different reports, all of which are produced using reproducible analytical pipelines. I'm talking to you about one of the reports. Next slide, please. So I'm talking to you about the MRSA screening compliance reports, but actually every Tuesday, all of these reports are produced using a reproducible analytical pipeline. So I could be giving you a talk about any one of these. That's key, because what it tells us is that when you've produced a reproducible analytical pipeline to deal with one problem that you want to improve on, then you can actually just modify that underlying code to solve other problems. So for example, here we're talking about checking to see whether somebody has been screened for MRSA on admission according to trust policy, but naturally you might also want to know which antimicrobials are the patients who are MRSA positive on, and are those appropriate antimicrobials for someone for an MRSA infection. And there is a RAP that we run every week that checks to see whether someone's prescribed the right antibiotics as well. And because there's a lot of interest in MyTrust now in regards to this kind of process, the RAP, we're now expanding beyond infection control and microbiology as well to, for example, look at the prevalence of lipid-lowering agents in patients who've got massively abnormal lipid profiles. The principle is the same, that you're extracting data from multiple different silos, analyzing it, wrangling it, and producing outputs. Next slide, please. So yeah, we started this project in Jan 25, and I use SPC charts to detect meaningful changes in compliance with MRSA screening. Here, there's a quick shout out to the NHS R plot the dots package, which is available in R, which is produced using produced by the NHS R community, and is a great example of open source communities building tools that are freely available. I should have also said that this whole process of the RAP is entirely free. Thank you. Next slide. So we are looking at all current inpatients with a length of stay of more than 24 hours who've been prescribed a new inpatient medication in the past 7 days. And we excluded patients who are in hospital for more than 6 weeks, just because the data size becomes so big that it becomes a bit unwieldy. But the average inpatient stay in our trust is 5 days. So not many patients stay in hospital for 6 weeks or more. And of course, we excluded patients who were exempt from the screening policy as well. Next slide, please. So here, this slide just shows how many patients were monitored each week. As you can imagine, if you are monitoring thousands of patients every week, then that would be a massive undertaking if you were doing that manually. And next slide, please. And here we can see the number of inpatients who are compliant with MRSA admission screening. So you can see that over time, we've increased the number of patients who are screened. Next slide, please. This is the same data as a proportion. So how many patients percentage-wise were compliant with MRSA admission screening. And I think what's key here is that at the start of this journey, everybody that I spoke to thought that our compliance rates would be quite high because it's mandatory, right? It's mandatory part of the trust policy that people are screened on admission. But if you look at the very left of this chart, what we see is that less than half of inpatients who are eligible for MRSA screening were being screened. So it's not enough to write a policy saying that it must happen. It's really, really important to actually check to make sure that what is thought to be happening is actually happening. And I was really surprised by quite how poor our performance was right at the start of this journey. And rapidly, you'll see here that as soon as I started sharing information about which wards were doing better than others and which patients were not being screened who were thought to be screened, then without me actually intervening in the patients themselves, just by sharing the data, over time, compliance with the policy increased significantly. Next slide, please. Really importantly here, just to go on a slight tangent, the assessment suite here called RVAS in Newcastle is where most patients enter the hospital. So you go through the emergency department and you end up on the assessment suite in most cases. In February 26, amongst the wards doing the most screening, the assessment suite didn't feature. Next slide, please. They started paying attention to the data, and by the 10th of February, they were the 6th highest screener. Next slide, please. By mid-February, they were the highest screener. Next slide, please. By the end of February, they were overtaking the assessment suite at the Freeman. Next slide, please. And now, if we look at present day in June 2026, then you can see that assessment suite, as you would hope, is now the top screening location for our trust. Next slide, please. So when we plot the timings of that on this graph, you can see that without the assessment suite, we managed to increase compliance with MRSA admission screening to approximately 65%. And then when the assessment suite started taking this data and reviewing what was actually happening and trying to improve their own performance using the data that I share every week, then now we're approaching an MRSA admission screening compliance of just under 80% week by week. Thank you. Next slide. So to give you a bit more insight, what I do is I share information on which wards are doing best and which ones could do better. So this was data from November 25. Next slide, please. So on the bottom right, you've got wards that require improvement. On the top left, you've got the best performance. And what I found was that ward managers were talking to each other to see what was going on. So it's obvious there that the assessment suite is amongst the wards requiring improvements. So that led to lots of discussions amongst stakeholders to try and improve that. And there was also discussion about how some wards were managing to do so well. So in November 2025, some wards were almost at 100% compliance with the trust policy, whereas other ones were at less than 10% compliance. So there was a huge variation in practice in different wards across our organization. And I think that's normal. And I think that's why it's really important to share this sort of data on a granular level that's applicable to ward managers locally so that they know how they are performing themselves. Next slide, please. So this is present day. So as you can see, because it's difficult to read now, if you press forward one more time, the best performers are now a very large group of wards because lots of areas are performing very well. And there's indeed 3 wards on this slide here where there's now 100% compliance for all inpatients for MRSA screening, and very few wards require improvement. None of them are doing as badly as they were previously. Next slide, please. So what is the impact of all of this? What I did was look at MRSA rates. So as we screen more, we are finding more MRSA. That's kind of predictable. But what I'm interested in is also what the impact is on the actual MRSA bacteremia rate. Next slide. So what we're finding is that the prevalence of MRSA amongst inpatients in our trust is now reducing. Using the plot the dots package here, we can see that that's something that is leading to us having fewer MRSA bacteremia in patients over time. And that's ultimately what we're aiming for to help us hopefully ascend the league tables rather than fall down them. Next slide, please. The other thing that's really key to the RAP's success is just how reliable it has been. So between Jan 25 and June 26, which is a period of a year and a half, of the 77 weekly reports that were expected, 75 were produced, leading to a 97% reliability of this process. And amongst the 2 times that we missed the opportunity to do a weekly pipeline output, one was because we didn't have staffing in the data science team, and one was because of a downtime of our lab information management system, which this RAP can't help with. And really importantly, there was no significant modification to the RAP workflow throughout. So we didn't have to really significantly amend the code at any point. We just ran the same code every week, produced the same outputs every week, shared them in the same way. And there was very minimal change to the underlying code. And if there is change to the code, it's totally auditable because the code is available in GitHub, and GitHub itself audits changes to code. So if I did want to see what changes were made to the code, then I could find it out there. Next slide. So coming towards the end of this presentation then, my interpretation here is that RAP-generated feedback constitutes a really effective mechanism to achieve rapid and sustained improvements in MRSA admission screening rates. It's extremely resource and time efficient compared to doing it manually, to the degree that it doesn't happen manually. Next slide. And to show you how we're doing compared to what's published in the medical literature, you may question whether our baseline performance was particularly bad. But actually, if you look at the available literature, and there's not a lot of publications on this subject because I think the data is so difficult to get to. In a Swiss study, baseline compliance was 32% for MRSA admission screening. Ours was just under 50% to begin with. In a English study, only 61% of emergency admissions were screened for MRSA, so again, comparable to our start-off point. And in a Scottish study, using self-selected areas, compliance was estimated at 81%. But as you could see from the data that I've shown you so far, compliance across the organization varies a lot. So if you only take data from self-selected areas, then I suspect that includes areas that are doing better rather than those that are doing worse. So I think when it comes to our baseline compliance, it's probably actually not that uncommon to have really poor baseline compliance with MRSA admission screening. And the RAP can help other organizations improve their performance perhaps as well in order to address the problem of MRSA admission, of MRSA bacteremias. Next slide, please. So a really important conclusion here also is that, as I mentioned before, the RAP can be readily modified to improve compliance with other time-sensitive measures. So as I mentioned before, the RAP in Newcastle has been modified to identify gaps in lipid disorder management, which then drives improved genetic screening for inherited rare disorders. So now we're finding that patients who were being regularly monitored for their lipid profiles, those patients are now being screened for example, familial hypercholesterolemia, and those patients are then being contacted by their GP to be referred to the genetics clinic for screening for lipid disorders. Those patients would have never otherwise been screened. We're also improving our processes for monitoring AMR data. And where we are finding antimicrobial resistance, we are better able to review those patients' inpatient prescriptions. We're also supporting pharmacogenetics interventions. So, for example, there's a genetic test available to screen for the gene that puts you at risk of deafness if you get given gentamicin. And now we can see which patients who've been prescribed gentamicin have been screened for that gene. We're also able to identify penicillin allergy delabeling opportunities. In Newcastle, I can tell you that week on week, about 5% of our inpatients are labeled as penicillin allergic. I can also tell you that many of them receive penicillins. And by looking at the Venn diagram and seeing which patients have been prescribed penicillins who are labeled as penicillin allergic, then we can delabel those allergies, which saves a lot of money because penicillins tend to be cheaper than non-penicillins. And finally, the latest RAP that I've been working on is one that aims to improve recruitment to clinical trials. So one of our respiratory physicians in Newcastle is interested in having a look for particular patients with a history of bronchiectasis and COPD to see whether they have lab abnormalities, and then looking at that cohort that does have lab abnormalities to try and recruit them to clinical trials. So there's a huge scope for RAP improving compliance with all sorts of time-sensitive measures. Next slide. So what I really want leaders to take away from this meeting is that investing in RAP and data science represents a really important strategic opportunity to embed evidence-based practices. It's not enough to write a policy saying that something should happen. It's really important to monitor to see whether it is actually happening. And if it's not happening, then find out why. And RAP should be further scaled across organizations to achieve sustained system-wide improvement in multiple different dimensions of healthcare, safety and quality, not just infection control, not just microbiology, but I can think of many, many different ways in which RAP can be modified to help improve patient quality. And I'm really delighted that this work has been recognized, because hopefully we can work together to make this kind of pipeline more often used in healthcare. And massive shout out to the NHS Open Analytics community, which used to be called the NHSR community. Without the NHSR community, I would not be giving this talk, because I wouldn't have been taught how to code. So we need more clinicians who can code, we need more scientists who can code, we need more acceptance of code in medicine, or healthcare for that matter. And the NHS Open Analytics community provides free for NHS staff members training on how to code. And as I said, I used a package that's produced by this community to show you the improvement over time, because the SPC charts were all drawn using a package produced by the NHS OA community. So massive shout out to them. I hope that they last for a very long time into the future. Thank you. Next slide. This work has been submitted for publication in peer-reviewed journals. Next slide, please. Really key is that when I checked in November 25, there were 5 publications on RAP on PubMed. So if we are using RAP, we should shout about it a bit more and publish our outcomes more. And indeed, RAP, because you are producing outputs each week, facilitates production of outputs that can be published. So the preprint is available on Zenodo of the information that I've shared with you. Next slide, please. And again, massive thanks to my whole team. There are references on the next slides, but I would like to leave it on the picture with all the people, on the slide with all the people, because I think it's really, really important that we invest in the capability to do this sort of work, and that does rely on humans being present. The work I've presented to you does not involve AI. I can do AI work in R, but it's all the work I've shown you is very deterministic. So you don't need AI to do good quality improvement work. AI may be part of the solution, but it definitely isn't the whole solution. And it can't be the whole solution because you need humans in the mix as well. And so it's really, really, really key to invest in the human resource that allows you to use data science pipelines. Thank you.
Thank you, Daniel. That was great. I mean, we asked for innovation. You've showed us innovation, so thank you. But what I liked is you used a system that actually some of us will be, not everybody, but some of us will be familiar with and have received training on, which shows how it could be reproducible. So thank you. Congratulations. So I'm going to hand over to Vicky. So very quickly, I mean, many of you will know Vicky Patel. So the last chair of NQI-CAN, and Vicky, you've done such a great job in the past of giving us our local perspective, and you kindly agreed to do that again this year. So over to you, Vicky.
Lovely, thanks, Caroline. And then literally just to reframe our thoughts then, I'm thinking for the next 5 or so minutes about how clinical audit then can move beyond measurement to actively supporting that innovation, transformation, those NHS3 shifts. And obviously the example that we've just heard from Daniel and the winning team really supports that analog to digital really well in terms of innovation. So that was fantastic. So NHS 10-year plan's clear, we're shifting care hospital to community, analog to digital, and treatment to prevention, and audit then has to evolve with that. We can't add that burden, we need that smarter, faster, more targeted use of data embedded into care. So that real shift is from retrospective reporting to real-time improvement. And again, we've just seen that fantastically shown in our winning project. So if we move to that next slide then, and I'm going to go a little bit at speed in the interest of time, so bear with me. So it's about that focus on that mindset shift now from project-based audit to that live improvement. Traditionally, audit's been a project, fairly slow, fairly retrospective, but now we need that continuous learning. So move from retrospective to real time, that compliance to improvement, and then that central ownership to that team ownership, which again you saw come through in the winning example where we're putting data into teams' hands. So audit must move at that same pace as care, so it can no longer sit as that retrospective assurance process. It needs to become that live improvement tool embedded into daily practice. So how can we motivate our clinical audit teams and our frontline teams then to make that shift? So if we move to the next slide then please, this is about making audit relevant to the challenges that our frontline teams are facing every day. Then they will engage and they'll use audit to help solve those real problems like delays and variation, duplication, or even that poor patient experience. So instead of starting with audit topics, we start with service pain points. What's slowing care down? Where are patients experiencing frustration, and where is risk or even avoidable omissions happening? So we co-design the audits with our frontline teams, and that's where that innovation really comes in. And we align audit to the 3 shifts, whether that's preventing admissions, identifying missed prevention opportunities, or reducing digital inefficiencies. Because when audit helps teams fix what makes their day harder, they don't just engage with it, they use it to actually improve care. So if we move to the next slide then, we need to think about embedding audit into our workflow then. So the biggest barrier to engagement is often not resistance to improvement, it's actually workload. So we've got to redesign that audit so it sits within workflow rather than on top of what we're already doing. So that digital shift in the 10-year health plan is specifically about reducing admin burden and enabling our staff to use that technology more effectively. And again, that fits really well with the winning project that we've just seen. So we need to be proportionate in terms of sampling, focusing on what gives us actionable insight, not maximum burden. So if we move on then, please. So as fast as we're going through these slides, the future NHS needs that faster learning as well. So if teams are expected to adapt and improve in real time, then their audit has to operate at that same pace. So we need maybe short focus cycles, measuring, feeding back, improving quickly. It might be small audits over days or weeks, linking directly into improvement cycles and sharing results in real time through those huddles, those meetings and the frontline discussions. And using the data plotted in the SPC charts that we've just seen in the example puts that data regularly into the hands of those frontline teams. So we're keeping people motivated. They can see change happening quickly, and that momentum matters. They keep going. So we're just going to move on then and start to have a think about the 3 shifts then. So that hospital to community then, that's about delivering more care closer to home, maybe looking at things like reducing those unnecessary admissions. So for clinical audit now, we've mentioned it in day 1 and day 2 this week already, starting to think about using audit to measure those whole patient pathways from admission through to discharge to follow up to preventing those future admissions again. So the opportunity here is simple. Audit that patient journey, not just a hospital stay, for instance. So if we move to the next slide, I want to touch on analog to digital, which again fits with the example that you've just seen. So the digital shift is about reducing burden, improving access and enabling better decision making, and that's between our frontline teams and also our patients and the people that are using our services. So focus on whether digital tools are actually improving care, not just being used. So if we can move to the next slide, then we'll just quickly have a look at sickness to prevention then. So finally, the shift to prevention means making sure that we're identifying and acting on risk much earlier. So for clinical audit, that means not just reviewing what went wrong, but asking whether it could have actually been prevented. So we're focusing on areas like risk factor identification, missed opportunities during care episodes, and whether prevention advice and referrals are happening consistently, because ultimately the best outcome is not just better treatment, but preventing harm before it happens. Next slide, please. touched on this already about giving teams ownership of their own data. 10-year health plan talks about a more transparent NHS and a system where frontline staff are empowered. So one practical implication for audit is that teams shouldn't have to wait for a central report or results to know how they're doing. They should be able to see their performance over time and act on it. So this is about simple dashboards such as your SPC charts built into Power BI dashboards for clinicians to access wherever they are at any point in time to see how well they're doing. So next slide, please. So 10-year health plan also touches on the fact that within that then we need that capability, that confidence and that clinical leadership then to be able to use the data and information more readily at that point in time and make sure that we're interpreting it in the right way then to be able to inform those decision-making discussions that we're having in real time. So the plan specifically identifies workforce reform, innovation being a key enabler of change, and that means building data literacy, improvement capability, and that clinical leadership. So I'll quickly move on to the next slide then, because this has been a message again throughout day 1 and day 2 as we're moving into day 3. And this is about that focus on fewer audits, but making them higher value. So we know that we're in a resource constrained environment. And one of the most important things we can do is stop trying to audit everything. So the priorities should be fewer audits with stronger alignment to our strategic priorities, patient outcomes, inequities and our operational pain points, which I've touched on in previous slides. So if you think about your high value transformative audit topics, it's looking at equity of access to digital services or virtual pathways, those neighbourhood pathway audits for patients that are having repeated admissions, prevention audits for obesity, smoking, frailty, falls even, and pathway completion audits across organisational boundaries. It's across the system now, across that patient pathway. And then your digital workflow audits to identify where poor system design wastes clinical time. Not everything needs an audit. We need to move to fewer audits, stronger focus, and that greater impact. So then if we move on to the final slide then, we'll just look at more of a call to action really for you, and that is to really make sure that clinical audit really matters. This isn't something that we can wait for. It's not something that's going to be handed to us back in our own organisations. Everyone in this room, everyone working in health and care has a responsibility to make this happen. And that's because transformation doesn't happen in policy. It happens through what we do next. And that requires that real shift from measuring to improving, from compliance to learning, and from doing audit to teams to doing it with teams. So the call to action is fairly simple. Start the conversation, lead the change, embed the audit where it matters, and make sure that we're working in partnership and that we can actually prove the difference. Because if we don't do it, it won't happen. But if we do, clinical audit won't just measure care, it will transform it. So thank you. A little bit of whistle-stop tour, but I was just conscious of time.
Thanks, Vicky. Thanks for grounding us in the rest of the world. So I've left the impossible task for Daniel of answering a question in 1 minute. Looking at them, we've got a couple of questions here, and wrapping up, I think people are interested in sort of how reproducible is it, what expertise do you need, and how did you get it embedded in the governance? Perhaps you could say a few words on those points, please.
Yeah, thank you very much. So in our trust, we have a very, very helpful information governance team who help us go through the DPIA process, and the information services team is very helpful also at ensuring that access to, for example, the underlying data is done in a way that's sensible. And obviously not everybody has access to the underlying data, but those people who need it do get given access. When it comes to how reproducible it is, it's entirely reproducible and transparent, more so than probably any other audit method, because the data is consistently the same, the way of analyzing it is consistently the same, and the entire code used to do the analysis is freely available on Git to those colleagues of mine who I work with in the data science team. And more code these days used to do these sorts of analyses is made available publicly as well. So I'm really keen to get trust to support the use of things like Git and GitHub. and that way we can learn from each other's processes, improve each other's processes, and all work together on data science projects that will hopefully not just be of a benefit to my own trust, but also to other trusts, and vice versa. Is that helpful?
That's really what I've heard is work with your colleagues in your trust with the right expertise. Thank you. Right, we are at time. I must highlight to you, so next slide, please. We have a lot of exciting events for the rest of the week. There they are in front of you. Please register. We've got some great speakers. We've got Professor Ted Baker. We've got a mental health nurse, Tom Hunter. We've got a director of midwifery, Faith Shells, amongst others. We have got lots of speakers and lots of events. Patient safety tomorrow, and Friday, the Evidence in Practice Award. And I think you've got the data informed improvement event on Friday afternoon. So thank you very much. We are ready to close. Lacia, please do say if I need to say anything else.
Thank you for the excellent sharing as well.
Thank you to colleagues. Thank you to our speakers, and goodbye.
Everyone.